Although took the chair here, I also am the next one to ask questions, so I'll start. I'm having a little trouble understanding where a couple of you people are coming from. I can understand a big company having their employees and want to keep them in private, inside the company in some kind of a health plan. Because you got them trapped today. They're scared of losing their job, so they're going to accept whatever you do, and you can keep offloading the health care costs onto the public, onto the employees of the company. But what I'm having trouble understanding is what happens to the smaller employer who sounds like they're represented by the NFIB, but Mr. Conklin, I don't understand. You started out paying 5% of payroll, and now you're up to 10% of payroll?
No, Mr. McDermott, it's 20%.
So you're 20% of payroll. Now, I hear from your industrial your industrial organization there that if you have that kind of cost, well, you'll have to lay off people. Have you laid off anybody?
No, sir. In fact, we just recently hired up.
So the fact that health care costs go up does not mean that, to the employer, does not mean you're going to lay off workers.
No, I mean, we have to offer that benefit in order to attract workers. It's an expectation.
So at what point, I mean, you're paying, I can't quite tell from your testimony because I read it all. You're paying $8,700 per person?
No, $8,700 for the company. I have 10 people.
Per month?
Right.
So that's $870 per person per month.
Right, and I want to make sure that for the record that this is well understood. This is during the transition. Now what's happening is I have some employees coming off our old carrier and going on to a new carrier, and while that's happening, I have to keep the old policy in place and pay a percentage of the new policy. Now this process is taking 2 to 3 months, so we'll have $8,700 outlays for 2 to 3 months, and then at some point in the future, our old carrier, HMO Blue Cross, will return the unused portion, so to speak. But like all insurances, I have to pay it up front. And in order to maintain coverage for everybody until this process is complete, that's my premium expense.
Why wouldn't you want to have, given that story you just told, why wouldn't you want to have a public option that you could say to your employees, go to this public option, it's a generous program, it's as good as what I'm able to buy for you, and be able to get it for, say, 10% of payroll?
I have no difficulty with that. My hope is that if that option were available, and I would hope from this process that if it's done right, the public option would serve a couple of different purposes. One is, and it's very important, is that it would make it easier for me as an employer to understand and explain to my employees what they're getting for our money. Because they're making a contribution too. I don't pay the whole freight on this. And if we could do that, and there was a plain language component of the public sector solution, whatever form that public sector solution takes, then the private sector, which I think has some conflicts of interest that it tends to camouflage in the way it presents the product, would be forced to reveal what the real costs are.
Tell me how they camouflage it.
Well, they camouflage it by presenting me with a 3/4-inch thick booklet of arcane legalistic language that explains what the policy really is. And what I'm looking for is a very plain English thing that says, here's what you're getting. This is what the co-pays are, this is what that's all there, what the deductibles are, this is how much you're going to spend each month. But here are the limits of the policy. If you go into the hospital and you have a serious problem, and that problem is, let's say, cancer, the average cost of, say, a cancer treatment in the New York metropolitan area for a serious illness is, say, and I'm making all this up. I'm not, like I said, I'm not a policy expert, but this is sort of my thinking. And that problem, that illness, on average costs $1.5 million to treat in New Jersey, okay? Our policy only covers $1.25 million. You're going to be on the hook for $250,000 because when you go in the hospital, you sign that little document that says whatever the insurance company doesn't pick up, I'll pay. So one of the things I'm hoping is that if we have that sort of transparency in the process, then we can also have an honest discussion about medical bankruptcy. And then we're going to really know what health insurance should cost and how we can fully cover everybody. Until we have that kind of transparency, I don't even think we know how much health insurance really costs.
Do you have an idea what's a fair amount for a small business person to spend on the health care of their employees? 5%, 2%, 1%?
Well, it would be
8%?
Great. Look, it would be great if it was 1%. I mean, it would be great if it was 0.5%. But if it costs 10%, then as an employer, I want to pay 10%. And I want the guy down the street to pay 10%. I want the guy up the block to pay 10%. But if what we have to do to cover everybody is create a progressive payment system, I'll live with that too. When I started my business, and it was my wife and I, we had no health insurance. But we were young, and we were healthy, and as I said in my written testimony, we were broke. So we weren't going to go out and buy any health insurance. That's a problem that has to be addressed. I don't know whether you're going to be able to address that level of detail in the legislation you're considering now. And I hope that as this discussion continues, we realize that we're probably not going to get it right this time. It's probably not going to be perfect, whatever you come up with. If you come up with a public option, it's probably not going to be perfect. And if we don't cast it into stone or steel and say that it's a federal program, it can never be changed, but we recognize that through this process, we're going to have to make adjustments and improvements, then I think, great. Anything that gets it closer to a fair, equitable system that gets 100% coverage has to be reflected in my bottom line and reduce cost. That just, and I'm giving it to you from my perspective, which is on the street. You know, I was thinking earlier during the testimony that there used to be a TV program, Homicide, Life on the Street. This is sort of like healthcare, life on the street. And, you know, what I experience is something different than what I'm hearing from the other panelists, which is not to say that their testimony is inaccurate or that it hasn't been well thought out. It's just not quite, doesn't quite jibe with what happens in real life as I've experienced it.
You'd like a public option, you could pay 10%?
Absolutely.
You'd move tomorrow to that?
Well, you know, I'd certainly give my broker the opportunity to convince me that it wasn't a good idea, and if he could do it at a competitive rate and tell me why it wasn't a good idea in clear language, and if he had a competitor who was giving me the real information, then he'd be forced to do that.
Thank you very much. Yes, you want to give?
This whole issue about migration to a public plan, I think if we took a real-life example that I have, is that I don't think that migration is going to occur as quickly as others would suggest it is. And a case in point would be a couple of years ago, through a consortium, several companies created what was called retiree health access. And the actuaries in the IBM case thought that probably about 60,000 retirees would migrate to that plan. The first year was 2,000 people. I think there is a general reluctance for people to migrate away from an employer plan. So I think a lot of it is going to be driven off of the design, the cost structure, the access, and I don't think you're going to see that migration as quickly as some would suspect that you would. I think the second thing is when you raise the issue around cost, is there an argument that made, well, are you laying off people because of health care costs? I think Jerry said it quite appropriately. There's a trade-off of cost. If the health care is rising at 20% or 10% or whatever the number is, then you make decisions around what are my raises going to be this year? What am I going to do in investing in human capital? What am I doing for training programs? somewhere there's always offset. It's not incremental upwards. It's always trying to create a level playing field. So I don't see the migration as quickly as others do, just by real life. HAS.
Could I ask, though, one other question?
Sure.
If you lay people off at IBM, where do they go? Can they afford the COBRA option?
Well, first of all, we have a benefit continuation policy that's up to 6 months right off the bat, so that we pay for that, and they go beyond that with COBRA.
And at the end of 6 months, they're on their own?
Well, then they go to COBRA. They go to a continuation.
Then they go to COBRA?
Yes.
And New York, where you're operating, is COBRA enough money? Can you make out of your unemployment insurance enough to pay COBRA and the house rent?
Well, in the spirit of bluntness, you know, IBMers tend to be at the higher end of the pay scale. And so, you know, in the spirit of honesty, you know, our average wage is close to approaching $100,000. So you would assume there's some level of savings there to create that offset.
Okay. Thank you very much.
Well, no one's thinking about leaving IBM plan to go to any public plan.
That's what I'm suggesting.
I know you are.
Yeah.
It just makes sense, and not every plan is as good as yours, but the plan that we're talking about is when Mr. Conklin sees his competitor with nothing and he's paying this large amount, he wants everyone to get in there and share this so that his competitors would include health care as a part of doing business. And it just makes a... Mr. Dennis, you stationed here, you're here in Washington?
Yes, sir.
Talk with my buddy from New Jersey. Because, you know, you got the theory and everything, but like he says, he has to deal with this every day. It's a cost on him. And I'm not talking about compassion. I'm talking about saving money, having people working every day, not having to worry about their kids getting sick or their wife not being able to get medicine, but being able to concentrate on making some cabinets. But a person in trouble with no health care is not a productive person. And so, you know we got to do something about it. And I would rather work with you so that we can get bipartisan support on this darn thing. You come in with something, you talk with Mr. Conklin, and if he's convinced, we got a deal. Let me call on my hero of the Congress, Mr. Johnson.
Thank you, Mr. Chairman. You know, Mr. Dennis, the Economic Policy Institute's proposed imposing a health care pay or play mandate on businesses, and their proposal would require employers pay 75% of individual premiums and 66% of family premiums for all employees working at least 20 hours a week. Employers who can't meet these requirements would be forced to pay 6% payroll tax. The Lewin Group estimates this would represent a tax increase of nearly $1,600 per employee. Is this mandate the type of thing that small businesses could afford?
Well, first of all, let me just say this, Mr. Johnson, that whether you call it paying for the premium, pay or play, or a payroll tax, is the same thing. So, I mean, we're talking about a generic group here that's equivalent to one another. If initially the business has to pay $1,600 per employee, then they have 10 employees, that's $16,000. $16,000, the question is, where do you get that money? One of the places is you're going to have to take it off your salary. I don't think any of us want to have $1,600 taken, or $16,000 taken off our salary. So, I mean, yeah, I mean, this is just another mandate. It's going to end up in lost jobs. It's going to end up, we've already talked about how employee wages are depressed because of benefit costs.
Well, listen, it seems to me, and I had a small business at one time, if you're not making money or on the margin a little bit, you're going to have to, you can't afford another increase. Well, what you'll do is probably lease out your medical stuff. You know, fire the employees and work them out of a different organization. You know, I don't think any of you realize what it costs to run a small business. It's not a simple operation, and some of you know. You work sometimes, some months, just to make ends meet. And if we stick you with another tax, which is what that is, I don't think you're going to like it. Mr. Conklin, I don't think you would either.
Well, I think, Mr. Chair, or Mr. Johnson, there's one really important point in this, and that is we have about 5.9 million small employers in this country. Some of them are doing very well. Sounds like Mr. Conklin's business is doing quite well. That's great. I'm all for that. There are some others that aren't doing so well, and there are some others that are just starting. So the condition of each business is very different. And I'm not talking about one business. I'm talking about the group of businesses, all of them together. Some provide. And I think the very fact that there's a relationship, and I will repeat, there's a relationship between what you take out of the business and whether or not you provide health insurance, employee health insurance, direct relationship. I think that speaks volumes. When a business does well, the employer does well and the employees do well. When a business doesn't do so well, the employees don't do so well and the employer doesn't do so well.
Yeah, I know. There are some companies that provide health insurance. Exxon's one of them, and about 20% of their people don't take advantage of the program they offer because they think they're bulletproof. You understand that. 21 to 35-year-old guys, and in fact, one of you testified that you didn't have insurance for a while. I think it was Mr. Conklin. Well, I appreciate, Mr. Conklin, the efforts you've taken to continue providing health insurance for your employees, and I've heard from a number of small business owners just like you who are finding health insurance to be increasingly unaffordable, and we need to reverse that trend. You mentioned the inability to pool employees and spread risk the same way large employers do. I wonder if you'd support reforms that would allow small businesses to join together and pool their risk. You know, association health plans never have been passed up here. And the independent guys, i.e. realtors, for example, are all for that kind of a program, and they don't have health care, a lot of them. So doesn't buying in bulk for supplies reduce cost?
Yes, Congressman, buying lumber in bulk does reduce cost. I don't think you want to use the same model to determine what you're going to buy in health insurance. And I think one of the problems we have in the discussion we're having about health insurance is we keep applying this business model as if we were talking about widgets. But what we're really talking about is people, and we're talking about the kind of care that's available to them. And when these larger groups, the question I have, and I can't, again, I'm admitting I'm not a policy expert, but the question I have is, who's going to determine who my carrier is in this larger group? Because we're going to form an association, and we're going to go out in this group and shop for health insurance. And then we're all going to somehow agree that the best provider of health insurance for us is the XYZ company. Now, I'm not sure who makes that decision. I'm not sure what that decision is based on. And we're still stuck with this sort of opaque process by which I don't really have a choice. I have an option. Join the association, shop for health insurance in the open market.
Well, association health plans don't have to be one provider. It can be 5 or 6, and they can pick.
Right, and we're still there, though. I mean, we may be saving a few dollars on the side, but the group and the way the group is structured and the available selections are still limited within this organizational model. So I don't see that as being a vast improvement over the system.
Well, it is, because they don't have any insurance right now.
Well, look, I said earlier that all the solutions, I used the toolbox analogy. If that's a tool, if that tool functions the way some people are saying it might function, then it may be useful to add it, but it's not going to solve the problem.
Congress, do you mind if I respond as you brought up my employers?
Go ahead.
Okay, thank you. you had brought up the estimates of what it might cost, 6% of payroll for small employers to contribute. What was also brought to light in that research that the Lewin Group did analyze is that via the national exchange with a public plan, small employers who are currently offering insurance would actually experience windfall savings with that kind of a framework. In fact, firms with 10 or fewer workers would save about $3,500 per worker compared to even lower savings that you would see across all firm sizes. So small firms stand to gain a lot from that kind of structure.
Thank you, Mr. Chairman.
Thank you, Mr. Chairman. I commend the panel. It's been a very interesting discussion. Mr. Conklin, you know, you're the guy off the street. You have had compelling testimony today. Absolutely delightful. Start with Mr. McDonald. In your capacity as a leader within the HR world, let alone IBM, you would have an expert view on the notion of whether or not the employer platform ought to be a base for the delivery of health benefits in the first place. Some believe it's time to move off of that. I would tell you I disagree with that. I believe there's still enormous value, let alone the fact that we have got 65%, as Dr. Gould told us, covered with the employer model, that platform. I believe that we keep that part and build out, not blow it up and start all over. What are your thoughts on that?
Clearly, as I think I said in my opening statement, we shouldn't start from scratch, and that the employer plan is a base or a foundation. As I look at whether we want to talk about it in terms of a public plan or some individual mandate, you know, perhaps we have to migrate there over time. And I think part of the issue has to be that you use employer-based plans as that model. Employer-based plans typically have a foundation for wellness. They have a foundation for preventative care and a foundation for primary care. Those are, I think, absolute critical components to any plan that's designed, whether it be at a large employer or a small employer. Or
Mr. McDonald, how about Medicare? I mean, I'm dismayed that those elements do not seem to be advanced effectively in present Medicare reimbursement incentives. Have you been able to achieve a greater role for primary care, preventive care, wellness, and impacted your cost curve? If so, I mean, you've got information that we desperately need to consider as we develop federal reimbursement policy.
I would agree with you on the inefficiency and the lack of effectiveness in the Medicare arena, and the answer is yes. For instance, in a 3-year study that we did where we fundamentally created what we call a healthy living rebate, where we focused on nutrition, childhood obesity, physical exercise, and smoking cessation, we invested around $81 million, and in that 3-year period we saved $200 million. And at the same time, we had a high-risk population that we identified to about 13% of our population. 55% of that high-risk population is now down to less than 7%. So we see a direct correlation for making investments in areas of preventative care, primary care, that yields returns.
Did you elevate the role of primary care in your interaction with your insureds? Is that how you were able to obtain the behavioral modifications that produce this positive health result? Or?
It's a two-prong approach. Yes, working with our carriers and other insurers that we work with, that was one way we created designs off of that. But part of that investment was a significant investment in making the employee and their dependents educated consumers. Let me just give you an example on childhood obesity. You know, you'd say, well, why childhood obesity? They're not your workers. Well, it's also a statement of society, but more importantly, it really reflects that if an employee goes to work and feels good about their family situation, and there's not an issue there, they're going to be more productive, they're going to be more satisfied. And one of the things what we did is we created IT tools, not surprisingly, for people to go on and look at what does it mean to have nutrition for children and exercise programs. One of the interesting byproducts was that in coming back with the surveys, we found it was more family friendly. People began to discuss what they were eating at dinner, what they were doing during the day. A simple thing like not watching TV more than 1 hour and the type of TV that the child was looking at, not being a couch potato. All those types of things helped immensely in intervening in those costs.
Now, your confidence in your plan indicates perhaps to me that IBM would be one in a new insurance world where large employers could continue to offer what they have been offering or send their employees to shop in an insurance exchange. You might very well continue to do exactly what you have been doing.
Regardless of your aspiration about a public plan or not, the thing that I would caution us as patriots, using Chairman Rangel's approach of describing us appropriately so, by the way, we have to ensure that we're still engines for innovation and transformation. I mean, what I just was describing to you was a sense of transformation within the healthcare arena. And I think that that has to be a fundamental premise of what we're doing going forward. I agree, by the way, with Jerry, the whole concept of taking out the exclusion for tax deferral, we would completely agree, and I think there would be a mutiny at the gate, so to speak, if that were to occur. So I think there are fundamental things that we have to maintain.
Mr. Chairman, may Mr. Shea also respond? My time is about.
Thank you, Mr. Chairman. I just wanted to piggyback on Mr. McDonald's comments and to make the point that I really don't think it is useful for us to see this as either or. Either Medicare is good or private is good. If you look at the experience of people who are working, have been working together, and I'm talking about large employers, small employers, purchaser groups, consumer organizations, and I would put us in that category, or AARP, physician groups, hospital groups, about how do you restructure the system to give better value. A key component of that is what the government does. We can do these things if we do them together. That's the lesson from what's gone on over the last 10 years, and I think Mr. McDonald would probably agree. It's really, you know, Medicare has led the way in terms of quality measures and quality reporting. And they've, with a fairly modest investment, they've got every acute care hospital in the country reporting on a standardized set of measures. And one of the things that the hospitals will tell you, the employers will tell you, is we don't want to have one measure set over here, one measure set over there. Medicare instituted a uniform set of measures that everybody reports on. And we know from the statistics, even in the first 5 years of that, that has improved quality. The performance has really improved on those measures. That's something that Medicare did that the private sector wants to emulate and be part of. So it's really a matter of working together. And one of the things that bothers me about the debate over the public insurance is it's like we're back to yesteryear. This is the polarized debate, in my humble opinion, which has prevented us from straightening out our healthcare mess for now decades. It is that precise kind of thing. The only reason we talk about the public insurance program is because we think it's good cost containment mechanism. If the private insurers want to come up and present a credible case that they can control costs, then we'd be very interested in hearing it. But their history does not indicate that they can make that case based on what they've done in the past. So therefore, we simply say, well, let's try the public insurance alternative and see if competition might get us someplace that the private insurance market has never been able to do. We're not enshrining a public insurance program. We're trying to get these costs under control.
Mr. Chairman, I thank this excellent panel.
Mr. Brady from Texas may inquire.
Thank you, Chairman. I agree with Mr. Conklin. The churning of health insurance adds to the problem in a great deal, not just in the private sector. We had Texas Children's Hospital and the Texas Medical Center create a nonprofit health insurance program, try to lower costs, and they failed, as they told me, mainly because small businesses have to move from insurance plan to insurance plan every 1 year, 2 year, 3 year, as they did in my small business, to try to contain costs. And until the point from the leaders of the children's hospital is that until you connect behavior of that patient to their health care plan, prevention, other initiatives won't really help. I want to describe to you a model that I found in a small town in East Texas, in Evadale, Texas, just north of Orange. There they've got a paper mill, and 7 years ago the paper mill management and the union there, the steel workers, agreed that the steel workers would run the health care plan. What they did was put together very common sense patient consumer model that had three parts of it. One, they built a clinic at the front gate of the plant. so that every union, there were 3,000 workers, every union worker and their family had immediate access to preventative care. When the family, child, whatever got ill, immediate access. Secondly, they went out to bid for imaging and specialty services, even had insurance companies bid on that, put together a list of good qualified specialty imaging services. Thirdly, they hired a navigator, a group that would help their members navigate the healthcare system to the point where if you had a chronic disease or multiple illnesses, they would send a nurse along with them to go from doctor to doctor and then sit down with that steel worker to work through the options to continue the medication, make the right decisions. Very basic process. The company pays an average healthcare cost. This group, who I visited with, toured the center, sat down with the groups, haven't had a healthcare premium increase in 7 years. When you talk to union workers, they say, look, if my child gets sick, I take them to the clinic immediately, because if I don't, not only do they not get well, but that money comes out of my pocket. When they needed to even blacktop the front of the clinic, the union workers said, no, don't use our money for that. Just buy the materials. We'll do it because that's our health care money. You talk to the doctor who was there, who's hired by the steel workers, said, I'm practicing medicine the way I always hoped to. Instead of spending 15 minutes with the patient, 15 minutes with paperwork, spends the whole 30 minutes providing quality care. One, because he loses his job if he doesn't, but secondly, he said, I don't have to worry about them suing me. They're not anxious to sue themselves because it's their health care money. And then talk to the PA, and they were all cross-trained in the office, and their point was that one had worked at another institution, and because at a hospital, and if someone came in with a sore neck, they checked the insurance policy, and if this imaging was allowed and that imaging was allowed, everything was run, mainly because they could, and secondly because they lost money on the ER and the uncompensated care and Medicare. So we said, we don't do the cost shifting here, we don't shift costs. Bottom line was, there was a direct connection between the behavior of the patients, of those who were being covered, and the health care cost. I'm convinced that no matter what model we create, now that was for 3,000 workers, so it wasn't a big model. In fact, smaller may be better if we're going to try to connect the consumer to the health care they get and the ultimate cost of it. And my question is, regardless of what model we pick, how do we really change behavior to prevention, to immediate action, to quality care, if we don't, in whatever we do, connect that informed consumer, provide them easy access to prevention, and make sure they understand that those are their health care dollars. And I would just open it up to the panel for any comments you have.
Can I get a job at that? At that mill? It sounds great. If you could come up with a workable model for a company of 13, I'd say, we're in. And again, I would say that these are the kinds of examples and these are the kinds of ideas that we really need to think through carefully and see how they might apply within the broader marketplace. Mm-hmm. One of the problems I see with that example in our part of the country is that
well, it isn't geographic. That model works wherever you take it, as long as you tie those
may or it may
divisions
not.
together.
It may or it may not, and it may work at 3,000 and not work at 20.
Well, obviously, a model like that, I don't want to cut you short, but let's get serious.
Yeah,
We're not talking about that model for 13 workers or 20. You're talking about putting together an amount that can create that synergy and do that bidding.
Yes.
Any other comments?
Congressman, I might suggest that one of the ways of doing that is to kind of focus on, some of us are old enough to remember this. I'm not suggesting that we go back that far, but when the physicians visited us at our homes when we were in those young years. But I would also argue that now one of the things that we have done to incent that behavior that you discussed is really trying to focus on the primary care physician, making that, if you will, using a sports analogy, the quarterback, the ability to kind of coordinate care, the ability to try to take that medical home approach. You talk about paperwork, the inability, and that's what it is, the inability of either the doc or the hospitals or the insurers to have a coordinated effort around the IT function that needs to be brought into the system. Those are 3 or 4 things that could be done readily and already have experience that have actually proved to be very beneficial to an awful lot of people.
Good. Great. Chairman, thank you.
The members shorten their questions so that within the 5-minute period, we might get the benefit of our distinguished guests that are here, because it's embarrassing for the chair to cut off the guest when he was asked the question and time wouldn't permit it. But having said that, we'll go on our side to the gentleman from New Jersey who brought the guest here, Mr. Pasquale.
Thank you, Mr. Chairman. Thank the panelists. Excellent, all of you. I contend, Mr. Conklin, I have a question for you and I have a question for Mr. Dennis. I contend that an important part of health reform is providing at least a minimum benefit to ensure that individuals have meaningful coverage. Without this component, I fear we will have a race to the bottom that leaves many sick people behind and others with coverage that fails to meet their needs. Some have argued that a health reform package that provides for minimum benefit will restrict employers' ability to tailor the benefit to the employee's needs. In your testimony, you highlight the experience you faced each year when you were shopping for coverage, to use your word. As I understand it, there is relatively no choice in either what you're able to offer your employees and consequently no choice in the options among which your employees can choose. Now, this is a problem that's not just unique to your business. I think you'd agree with that. My question is this. Given your experiences in shopping for coverage that meets your employees' needs, do you really believe that a minimum benefit standard would impede your ability to provide adequate coverage to your employees?
No, Congressman, I don't. I think it would be one of those very useful tools in helping us evaluate and understand what that minimum, we don't know what that minimum is. I don't know what it is, and it would be great if somebody could inform me in that way, and my employees.
Thank you very much. Now, Mr. Dennis, in your position paper, one of the primary points made against an employer mandate is that it fails to address the real problems of the health insurance market for small businesses, which is primarily affordability. I agree with you to a point. An employer mandate alone will not even begin to solve the problems. But I would like to make it perfectly clear that no one here has claimed that making any single change will solve the problems of our health system. You haven't heard that from anybody on either side. In fact, 4 of President Obama's 8 health reform principles addresses cost growth and affordability. So I venture to say that affordability is the single most important issue in this debate. On that note, I'd like to point out that some of the options you've provided us in reducing health care costs include expanding high deductible plans, this is in your testimony, preempting state laws that serve to provide assurances of adequate insurance coverage, it's there, attempts to allow employers to offer the most bare-bones policies. Now let's get down to the nitty-gritty, because I've heard some folks from the other side, my good friends, you would almost think that Medicare was a bare-bones plan. So my question to you is this. How do more bare-bones policies that ignore state laws and fail even to cover reasonable benefits provide protections for individuals, particularly those with chronic conditions or complex health care needs? Are you suggesting there for Mr. Dennis that we ration health care? Is that what you're suggesting?
What we're talking about when you're talking about a minimum benefit plans, you can have one with virtually nothing in it, or you can have Cadillac after Cadillac after Cadillac of plans.
Now, we're not talking about that kind
Well,
of
no,
a
just a second,
distinction.
sir.
Nobody on either side, sir, has ever said it's an either-or proposition.
Oh, no, I'm sorry. I didn't mean to leave you with that impression. But I'm
Good.
saying that there are two extremes to this. You can go either very, very small, very bare bone, or you can go very expensive, let me put it that way. And there are all kinds of gradations in between. Whenever you set a minimum policy, whatever that policy is, there will be, that's the level from where you start, and that's obviously the minimum benefit. It can be either a very good policy or a very poor policy.
It could be a good policy or a bad policy. I want you to take notes of that.
No, but it's directly, my point is that it's directly tied to cost.
I understand. Makes a lot of sense.
Directly tied to
Move on.
cost. And so what we're talking about here is a cost issue. And I'm not sure if maybe I don't understand the question.
No, we can't go through the question again, but it makes.
I thought the question was pretty clear, Mr. Chairman.
Well, anyway, we got to move on, and we certainly appreciate that on our side. We have Mr. Rhine waiting.
Thank you, Chairman. Mr. Shea, I enjoyed the point you made before. I actually agree with a lot of what you had said, which is, you know, the current system's not getting costs down. We're not attacking the root cause of health inflation, and I don't think anybody's going to try and defend the current system from that perspective. I guess there's just going to be two big different approaches here on how best to attack the root cause of inflation, health inflation. And we need to do a better job of offering an alternative if we don't think that this is the plan to go with. On that front, is it Shields or Shiles? Shields, okay. I've been on the floor with the budget all day, so I apologize. I just arrived. I want to get into your actuarial analysis of the EPI plan, and Mrs. Gould, if you want to jump in, because I don't want to unfairly characterize your plan. Walk me through what it seems to me sort of a death spiral of private plans that occurs. How do you arrive at the $119 or $120 million figure whereby people lose their private health insurance and go onto the government plan, as you've done in your analysis?
Well,
what's the dynamic that occurs that makes that happen?
the dynamic that occurs is that people are going to gravitate to the lowest cost plan. The difference here for a family in annual coverage cost is $2,500 a year. That's shoes for kids, it's getting the car fixed, you can go to work. It's for uninsured people, people living those things are very, very important. So it's a huge amount of money.
And that is because the payment rates are set at the Medicare rates?
That's right.
Which are lower on average than the private pay rates?
Substantially, yes.
And because of the cross-subsidization that inevitably occurs with these lower rates than the private rates, more people going toward the lower public rates will push up prices in the private rates, making private insurance that much more expensive.
Would the
Is that
gentleman
the spiral that occurs?
yield?
No,
Mr. Ryan, I'm sorry, just would the gentleman yield?
not right now. Thank you. So go ahead. So
I don't think
this
this isn't the EPI policy. This is the public plan. That your EPI is a different.
Okay.
policy.
Okay, gotcha.
It's not the public program that people are talking about, though.
Okay, so your $120 million estimate is based upon the assumption that we apply Medicare rates to the public plan.
Yes,
rate,
if you were
correct?
to do that, yeah. We also show what happens if you are less aggressive in the pricing. Use private payer rates or use something in between.
Less crossover, right?
Right, and the idea is to sort of give people a sort of a smorgasbord of options so that you can look at what the impact is on providers, on cost shifting, and arrive at some decision of your own where you want to place things.
Okay, Dr. Gould, let me ask you then about your plan. Tell me if I'm wrong, please. Your payment rates here are income below 200% of poverty, premiums fully subsidized. Above 200% of poverty, you phase in between 200 and 300% of poverty, $70 for an individual, $140 for a couple, $200 for a family of four. Non-workers, different payment schedule, but the same for everybody based upon their income qualifications. Is that essentially?
You're talking about the subsidy structure
Yes,
for low
yes.
income. That's
Yeah.
correct.
And that caps their out-of-pockets, right, when you throw in the co-insurance and everything else, right?
That's correct.
Yeah. So here's my question and concern, and that's why I want to ask Mr. Shields and yourself. If we're going to pay the same for the services, regardless of the quality of the services, how are we going to expect the quality to improve? Meaning, not all doctors are the same, not all hospitals are the same. They don't give us the same quality of care. But if we're going to be paying the same rates for the services, regardless on the quality of these services, if a person has the same health insurance, which regardless of whether you're a smoker or you have bad behavior, if you're going to get the same deal, aren't we basically having a system where the good cross-subsidize the bad in the healthcare provision of services based on quality? And aren't we having a system where we're making it harder for us to incentivize healthy living and wellness management and those kinds of things if we have such a standard plan and the same fixed rates applied against providers regardless of their quality?
I think you're neglecting the employer-sponsored insurance will continue. And what we'll see is what we see with the examples with IBMs and other large corporations that are able to innovate with their delivery system and change those incentives. Those can continue. There's no question that those kind of innovations can continue.
I don't think we've talked today yet about the things that are really wrong with the healthcare system, the things that would really control costs. Controlling payments, controlling what we pay providers, it reduces your costs, but it doesn't affect the basic inefficiencies in the system.
Right.
We don't do anything here to correct the underlying problem in the system, and that is that the incentives for providers are way out of whack. We know that in some parts of the country you get twice as much health care as you do in other parts of the country, yet it's been proven that there's no correlation to your health status as a result. So there's a great deal of suspicion that much of what we do is just plain unnecessary. None of these proposals, the public plan proposal does not fix that.
Right.
It does mean we pay less for the services that we use.
But it doesn't address the root cause of health inflation.
No. I mean, in California, we worked on a workers' comp problem, and people say, you know, our utilization in workers' comp is 4 times what it is in the neighboring states. Well, we looked at it, but it turned out the costs were pretty much the same in the neighboring states. The difference was that in California, the payment rates were much, much lower. I mean, dirt cheap, low rates. And there was an increase in utilization that was generating the increase, the revenues, so they were able to maintain that kind of revenues. We don't want to move to a system like this. And I don't think that we have at all, with the public plan, whatever, I don't think we've gotten to the nub of the issue at all here.
Well, he's going to smack the gavel on me. There it is. Thank you.
Soon and very soon, the bells will ring, and we'll have a 15-minute vote, 2 5-minute votes, but also a new members being sworn in. And so it will be at least an hour that we wait from the hearings. We have 10 members who have not yet had an opportunity to inquire, and I'd like at this time to see how many of those here that having asked questions will be willing to come back at 2. And I can't hold the witnesses to have to stay here, but those that can, depending on the number of members that would respond, would make a difference. So by hands, those who haven't had an opportunity, how many would be coming back at 2? So I think at this time, after Mr. Blumenthal gets his 5 minutes, that we will then ask everyone that's left in order to ask a question and ask who they would want to answer. And I would ask the panel to submit an answer in writing and apologize to all of you for the awkwardness of this time. But I can't thank you enough for the valuable information that you've given to us. And I may have to see Mr. Pasquale's friend in New Jersey to get this all straightened out, because you told it like it was, and we understand that. So, Mr. Blumenthal, we got to stay as long as we can in your record.
Thank you, Mr. Chairman, and I'll try and adhere to your admonition in terms of short questions. I would just say that I was very impressed with the track record of IBM as being creative, promoting wellness. We've got some legislation we've introduced on a standalone basis to try and further incent that. And I appreciate the clarification that was made that a private, even if we have a public plan, there will still be tens of millions of people through the private sector driving those issues of cost containment and promotion. I have one specific question, Dr. Gold, just Gould, the reference that I'm hearing about people that are going to be crowded out, that we're going to be seeing if there is an employer mandate, that it's going to lead to significant job losses or reductions in wages. This is reminiscent to me of what we heard when it was argued that we shouldn't increase the minimum wage because that was going to have a massive negative effect. In my state of Oregon and others around the country, the higher minimum wage states actually appeared to be growing, not shrinking. Does the research on minimum wage have any application to having an employer mandate for health care?
It absolutely does. When we think about how firms paying for health care are going to be offset, you could think at the high end there would be different forms of compensation that could give, perhaps. At the low end, you're right, you're constrained by the minimum wage. But what we're talking about here, perhaps, is something like a 5, 6, even 7% payment that would be required. Compare that to the minimum wage. We've seen in the last 2 years a 27% increase in the minimum wage. It's out. We don't know yet really what the effects are of that on employment. But if we look again, as you say, to the minimum wage literature in the 90s, we can see that there were no employment effects of that kind of increase. And in fact, I would go one step further in saying if we were to try to really contain costs, and I think one thing that hasn't really been mentioned here is that the introduction of the public plan would actually do a good deal to contain costs and bend that cost curve. If we were to do that, it actually can increase the competitiveness of our firms.
Thank you.
I would challenge that. I think that literature...
Excuse me.
I think
my time...
I'm sorry.
My time.
Okay.
I ask a witness a question. I would like to ask another witness a question, if you don't mind. Is that all right? I would like to...
I apologize if I've offended you.
That's fine. I just want to ask my question to Mr. Conklin. You had referenced the byplay, that you're on sort of a merry-go-round, having to switch plans. You're going back and forth trying to... What impact does that have on you and your employees being on this healthcare merry-go-round?
Well, it has various impacts. One of them is uncertainty for me and my employees. So these transition periods cover a quarter of the year, in essence. And during that quarter of the year, people still get sick. They don't stop getting sick because we're changing our health plan. So there's always the question of which card do I use? And then there's the question of, and what am I getting? You know, is it going to be $25 when I go to the drugstore this time, or is it going to be $40? The co-pays. But really, one of the more significant impacts of the constant shifting is who's your doctor? And who's choosing your doctor? Because you're not choosing your doctor. The health insurance provider isn't choosing the doctor. I've got a stack. I almost wanted to bring them with you so you could see it. I've got a stack about this high that I've collected over the last 5 years of the list of doctors for each insurance company. Now, sometimes they cross over and you'll find them in there, and sometimes they don't. So if you're going to go to the doctor and get care, you're going to get it from somebody who is as familiar to you as the guy who drives a taxi cab. And how do you feel going to the doctor, sharing some of the most intimate aspects of your life with a perfect stranger? I mean, there's a disincentive to go to the doctor that's part of the system. And I think, and this I think is a really important part of this discussion, it leads to the perception that they're doing this on purpose. They're doing this to keep me from going to the doctor. They're doing this because it keeps their costs down. And there's an element of distrust that now has completely permeated the private insurance system. So there's a lot of repair work to do.
Thank you, Mr. Chairman.
Let's see what we can accomplish with the time that is left. Mr. Bastanti, why don't you inquire for a minute, and we ask panelists to respond in a minute so that we can move on, okay? Oh, I'm sorry. No. Mr. Bastanti arrived earlier, John. Mr. Bastanti?
I'm sorry.
Yeah.
Yep. Am I up? Okay. Thank you, Mr. Chairman. Mr. Dennis, President Obama promised if you've got health care already, and probably the majority of you on the panel do, then you can keep your plan if you're satisfied with it. But you have research that shows employers, and especially small businesses, that would stop offering private coverage because employees could receive receive coverage under a government plan. So wouldn't a bill that forces workers to lose existing coverage, as has been described by Mr. Shields, be contrary to the President's campaign promise?
Oh, I'm not going to get into that about campaign promises. But clearly, I mean, we have a situation that the current system itself, the current employer-based system, does not work for smaller firms. And we really, while you can start with the employer-based system as a system from which you work around, you can start as a base. Clearly, something has to be done at the bottom to help us on that in that regard. I look at it from the employer perspective. The costs are relatively high, and this gets to your point. There was a quote earlier about an 18% increase. There's another study that shows you get 78 to 83% of insurance equivalent, which is effectively the same thing. You have greater volatility of premiums because you're a small group. You have real hassle with consequences. This was brought up with your experience. Everybody agrees on this. A series of people who are business owners who are not experts in insurance, although unfortunately they're having to become in some ways. And we're talking about wellness and prevention. Small business, a 13-man firm? I don't think so. And then we have bizarre things that happen in this system. For example, you'll see that the small businesses are much more likely to pay 100% of the premiums than the large ones. 40% of small businesses with insurance pay the whole fare.
Interrupt you, but Mr. Kine, would you inquire for 2 minutes?
Great, thank you, Mr. Chairman. I'll try to be brief, but first of all, I want to thank Mr. McDonald for kind of showing us the IBM way, what upfront preventive investment does to drive down costs in a larger employer setting, and I think the testimony was real impressive. And hopefully, as we move forward on reform, we'll figure out ways to further incentivize what IBM and others are doing across the country, because a lot of this is a lot of common sense, the free market working to drive costs down. Mr. Dennis, let me agree with you in your opening testimony, where I'm afraid that if coverage gets out ahead of cost, this could become politically very dangerous, and the system could be very tough to reform. But I don't want NFIB to walk away leaving the impression you don't stand for anything, because I know over the last few years I've worked closely with NFIB, but not just NFIB, but AARP, SEIU, Restaurant Association, the realtors, to come up with, I think, is a very viable national purchasing pool plan that we've introduced on a bipartisan basis with tax incentives, with prohibition against risk rating, and also virtual HR managers for small businesses that could answer a lot of the problem small businesses encounter in the free marketplace right now. Could you comment on the wisdom of such an approach? Or
surely, and the answer is yes. And we've distributed an outline, I believe, to the dais of what this the basic current SHOP Act contains. But essentially, what we're looking at is a pooling mechanism, a very large pooling mechanism, where we're going to draw employers in, and we're going to cap or control the ability to rate on the basis of experience, health experiences, and claims histories, and that kind of thing. So it's a program that I think is effective, could work for small businesses. It won't solve every problem that the world has ever come up with for us, but clearly is a step forward. And I think I can speak for our legislative staff, which I'm not one, obviously, that they would welcome any member to join you in co-sponsorship of this.
Mr. Dennis, I think you'd also agree, if we do the proper health insurance reforms the right way, such as eliminating underwriting or rating based on health experience, that too could benefit small businesses.
Absolutely.
Mr. Heller, could you inquire for 2 minutes?
I will. And I had a prepared question, but I'll make it brief. Mr. Shields, what else are we not doing here on this panel?
We got to have a...
Well, I guess the basic concerns for me are the incentives in the system. For physicians, the incentives are to just provide as many services so that you crank out as many bills. We know, for example, well documented that if you slow the rate of growth in physician payment under Medicare, you get a 30 cents per dollar offset from increased utilization. We know those are the things that are out of control. We know what works in terms of cost containment. We've done this, we've seen it twice. Once is in the 90s. There's a terrific investment in managed care that was made by employers in the early 90s. The rate of growth in spending per worker declined from 18% a year in 1989 down to 0.8% by 1996. Adjusting for inflation, that's a net reduction in what we spend on health care. And then with the Medicare Part D program, this was a competitive market-based approach as well, and we all were gratified to hear that the program came in costing a great deal less than what we had projected it would cost. And again, this has to do with the competition that results. So I think that the idea that has worked in the past is forming integrated systems where everybody has an incentive to keep people healthy, everybody has an incentive not to do things that are unnecessary. And those models have worked. They're very unpopular. I'm talking about managed care. They can be pretty unpopular, but there are ways to build on that platform. If we've done it once or twice, we can do it again. So that's the direction I've tended to think in terms of.
Thank you very much, Mr. Shields. Mr. Chairman, I'll yield back.
You please inquire for 2 minutes.
Thank you very much. And I do want to point out, I know there's been some frustration, I think I hear from the panelists, that you haven't been allowed to or been asked very much about all the other actions we should take to help improve quality, improve efficiency, and contain costs. We have had other hearings, and maybe we could invite you back to discuss some of those things, but the fact is that my understanding was that this was purposely set up to discuss employer-based health care. I do want to say that I acknowledge Mr. McDonald, particularly speaking to health IT, and we've done great work on that in this administration already in investing in health information technology. This committee's done great work on that under Medicare. And primary care, we're very, very aware of the increased need for primary care providers, and in fact, I'm circulating a bill today that is going to address many of those issues, and I hope answer many of those questions. And I did want to also just second Mr. Kine's really good work and important work in terms of the market reforms for small businesses being able to join together to purchase care. The question I have is, has to do with other market reforms, and I think I would ask Dr. Gould to start with this, to reaction to the fact that we've talked about community rating, we've talked about of course, maintaining the employer-based system of care. I don't think that we're all talking about that, most of us anyway. But we do think, and I certainly do, that it's really hard for people to enroll. I think that, Mr. Conklin, you talked about this, that even when you have coverage, many employees don't take employer-based coverage, and either they don't sign up, forget to sign up, miss the 30-day notice, and didn't have to have a life-changing experience to sign up later. There are waiting periods for 6 months, so even if your employer covers you, you can't sign up. I think we want to change the playing field on this. So my one question is, could we, quick question, just maybe it's a yes or no answer if I could. What do you think about doing an automatic sign-up if your employer offers you health insurance? Dr. Gould, do you think we ought to do it like we did for 401k fees and just have people automatically signed up? Of course, they can opt out if they have coverage elsewhere. But you offer insurance.
The 2 minutes has expired if someone wants to answer yes.
I think auto-enrollment would be a great idea.
It's wrought with problems.
Congressman Roscom from Illinois would recognize for 2 minutes.
Thank you, Mr. Chairman. Anticipating the falling gavel. You know, just maybe a word, not really time for a question, but just to follow up with the exchange between Mr. Dennis and the gentleman from New Jersey. I served in the state legislature in Illinois for 13 years and served in the insurance committee. And what was interesting was, take Mr. Conklin's situation. Assume for the sake of argument that he and his wife, his business partner, decide that they're going to put a salesperson out on the road, and they need to get a vehicle to do that. And let's say that the vehicle is sort of the analogy for a health insurance policy, and the government comes in and says, you've got to have a really safe vehicle. And you may say, well, Ford Taurus is pretty safe, but there's a government standard that says, no, Ford Taurus, not safe enough. You got to put them in the best Volvo possible, and if you don't put them in a Volvo, you can't put them on the road. So you're in a situation then, as the owner of a company that says, oh, we really can't afford the Volvo. We can give them a Schwinn, but they're not going to let us do a Ford Taurus. And that's not unlike insurances like in the state of Illinois and other places where mandate after mandate after mandate after mandate comes in, and you listen to the testimony, and it's sympathetic, and legislatures end up voting in favor of these mandates, but are really blind to the cumulative cost that goes up. So I think that having a legitimate no-frills policy has to be a part of this conversation, and with that, I yield back.
Thank you. Bob Edrich.
Thank you, Mr.
Education
Chairman.
and
Mr. Chairman,
North
permission
Carolina.
to submit a couple of questions to the record for the gentleman. I'll only ask one question in the expediency of time. Mr. McDonald, we've heard from a number of employers, not just you but others, that how valuable it is as part of your health benefits that we really have a prevention and wellness program. And in your testimony, you talked about your healthy choice that translated into about an estimated $79 million in savings in health care claims between 2004 and 2007. And I happen to believe that preventive medicine has to be a part of any health system we put together. I just think without doing that, we don't get where we need to get to. My question to you is this: can you talk just very briefly about your program, about the specific cost savings? And secondly, do you have any data on this that you could share with this committee?
I won't give you the specifics. I'll respond in writing on the data, but there is an enormous amount of data that I'd be more willing to share. And I really think that the primary issue that we have focused on is trying to connect the employee and their dependents with the primary care physician. I think that begins to drive behavior faster than anything. The preventative wellness programs help, but the single most important focal point for us is the primary care, the medical home approach to medicine.
Thank you, Mr. Chairman. I yield back.
Thank you so much. John Linder, thanks for your patience.
Thank you, Mr. Chairman. Mr. Shields, how many Americans choose their health care provider or their health care insurance?
How many choose their provider?
How many choose their insurance?
I think it's 80% or more of those who are offered it. Most of those people have coverage from some other source.
How many of those people have it chosen for them by their employer?
Probably 30 or 40%.
Don't the employers make most of the health care insurance decisions in this country?
They have been, yeah. Yes, sir.
Mr. McDonald, what percentage of your payroll does IBM pay for health care?
As a percentage of payroll, it runs about 7%, but you have to remember that we have almost 300,000 lives, and therefore a lot of people, not a lot, but several thousand people opt out. So it actually could be higher, and plus our wage, as I indicated before, tends to be at the higher end, so that percentage is a little deflated.
How much does the employee pay? Does the employee pay X percent of the premium?
We're one of the few corporations in America today that give a free PPO plan to all employees.
If we had a public plan to compete with it, what percentage of employees do you think might opt for it?
Before I mentioned to you, in my opinion, that there would be little migration to a public plan initially. I think that people are very reluctant to change as it relates to health care, as evidenced with HSA. They've been reluctant. I think a lot of it is really driven off of design, access, and pricing. And so for me to opine directly on a public plan, I don't have the details yet.
Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Mr. Shields, you mentioned earlier that you were talking about why people would move to a public plan. You talked about cost savings and so forth, and seemed to imply that the only reason, at least the only one we discussed, was that you could pay lower rates to providers, and had a deleterious effect on the system. Aren't there other factors involved that may make it cheaper, like there's no profit component to the cost? There's also the potential of lower administrative costs, like those achieved by Medicare, that would allow the public plan to be less expensive.
We showed earlier in the testimony that the cost of private insurance administration, including profits, et cetera, is around 13.5% of benefits. Right. Under this plan, it'd probably be closer to 7% under this public plan.
Right. Thank you. Mr. Conklin, first of all, thank you for saying a couple of things which I've been saying, and that's why I applaud you for saying them. One is, we aren't going to get it right the first time. There are going to be thousands of unforeseen consequences that we'll have to work on, but we need to start on this effort. And secondly, that we're trying, I think this is the way I interpret it, that we're trying to apply business concepts to something that is not necessarily a pure business. If you wanted to leave your business right now, if you wanted to shut it down, if you had a better opportunity somewhere else, given, unfortunately, the condition of your wife, would you have an easy time getting insurance if there weren't some kind of public plan?
Actually, no, I don't think we'd have an easy time getting insurance, and the insurance we got would be expensive, and I don't think paying more in that scenario would yield better results for my wife. Right now, we have a pretty decent HMO, and we are paying for the best care she's ever gotten, 100% out of pocket.
Thank you. One final question. Did the Lewin Group, Mr. Shields, estimate or what did the Lewin Group estimate as the 11-year savings to national health expenditures under the Commonwealth Plan?
I believe it was $4.8 trillion.
4.8, just a significant amount. Thank you very much. Thank you, Mr. Chairman.
Thank you, Mr. Chairman. Would everyone on the panel agree that if an employee today is happy with and satisfied with their health plan, that they should be able to keep it? Is there anyone who disagrees with that comment? Mr. Shields, if a new government-run health plan was created and it paid providers Medicare rates, how many Americans would lose their employee-based health insurance that they currently have?
Be about 108 million people.
And Mr. Chairman, I have one other concern. I fortunately have been blessed to work with King County, Fort King County in Seattle, Washington. Great wellness activities, preventative health care plan. I'm concerned about saving $18 million over the last few years, promoting prevention, health prevention programs. Microsoft does the same thing. I'm concerned that if we move to a public health plan, a government-run health plan, I should say, that we may lose some of those innovative ideas, and I yield. Thank you, Mr. Chairman.
Thank you so very much, Mr. Chairman. Anyone on the panel, one of the main reasons that one of the main issues we run into with this whole health insurance issue is pre-existing conditions. And I just want to ask anyone that wishes to answer, what kind of incentives should be out there as it relates to government incentives to not only take on pre-existing conditions when we look at overall insurance?
Congressman, you know, the word comprehensive is often associated with reform in our discussion these days. And I really think it's worth bearing in mind that there are very concrete parts of that. One of those pieces is that we have to accept everybody into coverage. We can't exclude people because of pre-existing conditions. But the correlate of that is if we get everybody in and if we get them in from birth, we need to provide them with the kind of preventative care, with the kind of early detection, with the kind of management of chronic diseases that come up. That's where the real cost savings are going to be in terms of managing health care. So it's one piece of the overall puzzle, and it's important that we address all of them together.
Congressman, too, you have not only the pre-existing condition in the sense of someone coming onto a job, but you have something that a similar situation when they're in a job and they face, quite frankly, right now, job lock, which happens quite frequently in smaller firms. Someone will be in a job, have insurance, and then can't move to another job because of the health insurance situation.
Yeah, well, it's something definitely we're going to have to tackle, because I can see it even going down to almost
healthcare employment discrimination, saying, well, if you have a pre-existing condition, I don't need you in my group or in my company because you're going to cost us all more. Thank you, Mr. Chairman.
Been one of the best panels that we've had. I cannot begin to tell you how many members who have so many things to do with so many other pieces of legislation, how they've stopped by to say what a great panel this has been and how important it has been. I yield to Mr. Camp before we adjourn.
Well, I would just agree with the chairman's comments. Thank you all for being here. Appreciate your testimony very much.
And we regret most of you are veterans and know how it works here, but we regret the awkwardness here, but you made a great contribution toward our thinking. We got to have a health bill, and I hope all of you would feel that your input has been a part of what we're doing. Thank you so much. The committee stands adjourned.